Hello, everyone. I'm Dr. William Mansbach from the BCAT Research Center, back with you once again to provide another episode in the series Dear BCAT. In this series, members of the BCAT faculty answer your questions. Why don't we go right to it? Okay, so this question is from a physician from, I'm not sure where, the Midwest. So this doctor writes, I am the medical director of 8 nursing homes in the Midwest. When I assess cognition in the facilities and in our community practice, I often use the MoCA screening instrument. For those of you who don't know the MoCA, it's a common cognitive screening tool. However, in the nursing homes, rehab, life enrichment, and the social workers all use the BCAT. While I have heard of the BCAT from AMDA meetings, I guess that would be the American Medical Directors Association, I am not familiar with it. I have been on the BCAT website, but there are a lot of tests and programs to learn about. I wonder if you can briefly contrast the BCAT with the MoCA, maybe the basic takeaways. Well, this is a very good question, Jim. It's a question that we get quite often. How is the BCAT different from the MoCA, from the SLUMS, from the MMSE, from the BIMS, particularly for those who treat in nursing homes? So let me begin to address that. Now you're really comparing apples and oranges. So let me present 5 key differences representing, Jim, the takeaway points that you brought up. Okay, so first, the BCAT is not a cognitive screening tool. It is a multifactorial cognitive test. So a test and a screening tool, very different devices. So not only does the BCAT provide an indication of where a patient might be on the cognitive continuum, normal cognition, MCI or mild cognitive impairment, a subtype, probable subtype of MCI, dementia, mild, moderate to severe. It also provides 4 different factor scores, 3 of which speak to specific cognitive domains. So there's a factor score for memory, for executive skills or the executive functions, and for complex attentional skill. So those 3 factors also form a 4th factor, which is called the cognitive task manager. So all 4 factors are highly predictive of outcomes. Not only are they predictive of cognitive diagnosis, but they're predictive of functional concerns, which I'll get to in a moment. The second takeaway point would be that BCAT was very carefully designed, took many years to do this, to reduce the probability of an education bias. In cognitive testing, in cognitive screening tools, there are many biases that are very common. Probably the hardest, one of the 2 hardest to eliminate or reduce is education. The BCAT does not seem to have an education bias, unlike the MoCA and some of the other common screening tools that are out there. So that's a very important distinction. The second bias that is hard to get rid of is a racial bias. BCAT does not seem to have a racial bias. And in fact, it's been used increasingly often to be able to identify cognitive differences, perhaps across demographics, including race. Okay, so third takeaway would be the BCAT has a modified scoring system for visual and motor deficits. You're not going to find that in the other screening tools. This is important because we're dealing with a population that has lots of sensory and motoric complications. Number 4, the BCAT, in a sense, is reverse engineered. When I created the BCAT, I was concerned about outcome and function. I was concerned about predicting EDLs and IADLs. I was interested in predicting falls, predicting rehospitalizations, and that was even at a time where rehospitalization was less of an urgent matter than it is right now. Prediction is important. So those of you who use the BCAT have access to a number of crosswalk tables, which are able to give you information about what you should be looking for in terms of adverse events and functional capabilities, safety at home being kind of a subset of many of them. And finally, the BCAT is not a standalone instrument. It's actually integrated into an intervention system, inclusive of working memory exercises, for example, dementia programming, several different things that many of you use. And it's also tied to a mitigation program. The idea is, can we identify risk factors for dementia and do something about them? So as you can see, the BCAT is a test. It's not a screening tool. It's designed differently. It's different intentions than the MOCA and SLUMS, the MMSC, the BEMS, and many others. Takes about 10 to 15 minutes to complete, multifactorial. You can use the online scoring system, gives you a comprehensive report, which you can integrate. And there are key factors. These key factors are highly predictive, hopefully variables that you're really concerned about. So a little bit more about kind of differences between BCAT, MOCA, and others. I'd said that the BCAT's a test, it's not a screening tool, but there is in the BCAT test system, 6 different measures, there is a screening tool, which is the BCAT short form. So in some sense, it might make more sense to compare the BCAT short form with the MOCA rather than the BCAT, because then you're comparing apples to apples, screening tool to screening tool. The BCAT short form can be completed in 2 to 3 minutes, as opposed to 7 to 10, even 12 minutes for for the MOCA and for the SLUMS. There are 6 items only, but they pull from the cognitive domains of attention, executive skills, and contextual memory, which I think speaks to their psychometric robustness. The BCAT short form, while it's not the full BCAT, is associated with a number of different outcomes. So it's very good from a prediction standpoint. It's also linked to an intervention system. You can use the BCAT short form if you want to identify people who are likely to benefit from, let's say, working memory exercises. Another thing that you should keep in mind, Jim, is that many physicians in community practice actually integrate something called MyMemCheck, which is a free self-assessment. It's a cognitive self-assessment, although it can be assisted by family members. And MyMemCheck, good science, peer-reviewed, published. One of the advantages is that it can be done online in the privacy of a patient's home. There's a report that gets generated with MyMemCheck. It can be sent to you as a physician. It could be sent to anyone, family members, whoever the patient would like to receive this. And it was designed with primary care in mind, trying to close what we know now is a 2 to 4 year gap between when patients begin to recognize cognitive deficits before they actually talk about them with their doctor. So given the progression of dementia and given that many people become aware of cognitive changes with MCI, MyMemCheck might actually be very helpful for you, Jim, in your practice. Okay, well, I hope that was helpful in differentiating how BCAT is different from cognitive screening tools. As always, you can follow us on social media, Facebook, Instagram, Twitter, and LinkedIn. If you're not a BCAT member, please go to the BCAT website, www.thebcat.com, and sign up. Just register as a member. It's free. We don't share your information with anyone else. That way you'll get timely information about memory, about aging, about geriatrics, things that we think would be helpful in your work. Okay, very nice to be with you. I'm Dr. Mansbach. I'll see you the next time.